Istedin mi? Yes, sırtak spitball. Hello, dear colleagues, dear friends. Today we have patient with the AC aneurysm on the right side. We already done rotational angiography, and we started 1 hour before. We waited for the anesthesiology team. It's a Sunday today. It was expected IC aneurysm, but on IC there is a infundibulum of PCOM, and the second aneurysm on ACA territory. That's why that's why we gave general anesthesia, and now female is 65 years old, and just a second. No, my script. Okay, I will show you like this. Just a second. You can see the aneurysm on ACA territory, and from the bottom of the aneurysm there is a contralateral ACA. Okay. Okay. Then we did a manual compression, and the aneurysm is located on the ACOM segment, and the first aneurysm was A1 segment aneurysm. This is under local anesthesia. This is angio, and the coil mass is here. You can see there is distance between aneurysm and the previous coiled mass. And now the plan is balloon assist coiling, but maybe we need to check also the left side. We will see. Okay, today Yalalta and Sheikh Ahmed planning to assist me, and they put Chikai Black inside the scepter. It's okay, it's okay. I think Yalalta and Sheikh Ahmed prepared the scepter balloon, but I need to check because it's very important part of this treatment. And also patient has a 360-degree kink on the cervical part, so-called tonsillar loop, and it might be technical point in treatment of this aneurysm. We will see. Yes, this kink, usually it might be problem for the guide wire navigation and the instrument pushability, but we'll see. I did a small curve here and a J curve here. This is how many percent?
64.
60. Okay. I will put a little bit more. You already prepared this?
Yeah.
Okay, balloon is prepared. Now I will put in the water and deflate the balloon. Just. Yolta, what kind of balloons you are using in Ulaanbaatar?
Eclipse, high performance.
Eclipse, high perform and Scepter, yeah?
Hyperclad.
Do you have Scepter in Ulaanbaatar?
Yeah.
Yes? No Scepter? No, okay. Yalota came 2 weeks ago, yeah? Yes, nearly 2 weeks ago, and Yalota planned to stay in Astana, but unfortunately there is no financial support in Astana. That's why we brought Yalota to Almaty, and I think it was a good decision because in Almaty we have a good number of patients, and we can treat these patients with all kind of materials. It's better for the education, yes. And also Yalta can see the different type of techniques from my side, from Nurjan, Marat, Maksat, Shaykh Ahmed and Devlet. They're also showing different technique, different understanding of the problem. It's also important. All these young doctors were my students, but they're doing cases differently. Yeah?
Yeah.
Not like a
So
copy. It's not a copy. Yeah? It's different techniques. Okay. Let's see the
Position.
3D. 3D looks like this, and I think something like this would be, and it's look like ACOM is coming from this point, and it might be a little bit challenging to save the contralateral ACA territory. We will see after placing the balloon. Maybe we will do compression test again, and we'll see the segment. If there is a risk of occlusion of contralateral ACA, then we will place just a flow diverter Silk Vista Baby. We will see. 630 caudal. It's a right 6 and 30. 6. 30 caudal. Yes, we planned to do under local anesthesia, but patient said she has a pain in the right shoulder and she couldn't lie on the table for 1 hour. And the aneurysm is quite small, that's why we decided to switch for the general anesthesia. I think it's a better decision. And all for the patient. Okay, there is a technique from René. It's possible to went from this point, and when we push the instrument up, and then when we pull the instrument, the guiding catheter can go from this segment. Not so much. Okay, maybe I will use anchoring technique. We'll inflate the balloon in the IC. Is it 15 centimeter length balloon or is it 20 millimeter? Okay. Okay. We went from the 15. Okay. Okay, thank you. We went from the kinking segment and we brought the Fubuki 7 French to the Petrosal segment of the ICA. It may cause little bit spasm. Нематопты промывкаға саласаңызшы. Бақыт новый промывканы қойып ішіне нематоп салу керек. И мынаны переколимся. Третью систему подключите. Новую систему. Okay, I deflated the sector. Now the navigation would be. It should be easier, yeah. Okay. Okay. Like this, and like this.
Anchoring.
It's okay, it's a cardiology technique. I will open the flashing. And now there is no aneurysm. Eh? No aneurysm. Yes, because of bit spasm. We will flash some nimodipine and then it would be clear. Yes. Yes, aneurysm will appear. Okay. Yes, it's better to navigate in a straight vessel than angulated one. Okay. Just a second.
Первый техник был как вы сказали?
Жаңағы қойғаныңызға қосасыз. Жоқ, оны емес. Иә, новый. Все. Новая система. Так, назад сделай, пожалуйста. Артқа қарай жасай сал. 15 миллилитр нематоп. Yes. We will put 15 cc nimodipine inside the flashing system. Flashing is 1 liter. If we use 500 cc saline bag, usually we use 8 milligram of nimodipine. This technique I brought from Essen, from Germany, and I use this technique since 2013. No, from 2012. Okay. Yes. Yes, there is angulation. A lot of angulations, extracranial, intracranial. Okay. Let's try to go with the septer. Yes, I learned in 2012 a lot of techniques from my friend and teacher René, and I'm still using those techniques, yes. And all of them are reliable. It's a pressure cooking technique, it's a double balloon techniques, all of them. And moving from the tonsillar loop, also I brought from Essen. I learned during the ELIS course, one of the ELIS courses. Yes, and okay, we don't change the angulation of the headway. We will see. Usually I like to give 45 degree to the microcatheter, but today we will try to go with the straight one. The flashing is okay here. Could you give me the flashing with Naimodipine? The new one. Okay. I will switch from the pure saline to the flashing with Naimodipine. That's okay. That's okay. A little bit quicker. Go with the headway 17. It's a straight one, and we'll see. Yes, in such situation, better to have biplane system. Yeah? And now, Yalta, you started your career on biplane system or monoplane? In Ulaanbaatar, biplane, I think. Yeah.
Yeah,
Have you used some monoplane
no.
system? No, no monoplane. All the time biplane. Okay, you're lucky.
Yeah, me too.
Yes. I started on monoplane. Yes, and yes, it's useful to know how to use the monoplane machine. It's like a car with a mechanical box. Okay. The anatomy is not so clear. I will put more Nimodipine. Okay. Try to do more clear geography.
Давление 88.
Окей. Можно чуть-чуть приподнять далее. Хотя не нужно. Стоп. Назад. Стоп. Назад. Окей. Назад. Назад. Вперед. Okay. Let's try to go to the...
Сафос впереди.
It looks like I'm inside the aneurysm, but it might be also the ACOM. That's why maybe in some situation better to have two guiding catheters in both IC to control the territory. Okay. Now we can use the balloon. Yes, it helps a lot to navigate the microcatheter. Бақыт 2-де 6. Жоқ. Хотя оптима берсеңіз оптима бере салшы. Лучше аксиум бере салшы 2-де 6.
Şu жерден ангелиш деп көргенмін.
Okay, Shahmet is asking to do control angiography super selectively. We called the name of this technique is aneurysmography, but it might be a bit risky because you may rupture the vessel, you may rupture the aneurysm. That's why we will do aneurysmography with the coil. Okay. And also we can use 3D roadmap. Just a second. But 3D roadmap would be not so accurate because of 2 instruments and all this stuff. It's look like the instrument inside this, and balloon is deflating. Okay, let's inflate the balloon. Now it's inflated. Yes, and it's very important to feel the resistance of the coil and to see the resistance of the coil. Just a second. To change the tube B. Okay, I will pull the catheter a little bit.
Без него только.
Жоқ, просто несін без него топа сдуйте.
Просто сдуть. Жоқ, сдуть.
Yes, it's look like on 3D roadmap on this. We're inside the aneurysm. Optima bir жарымда 2 дайын дей салшы. Бірақ ашпай тұра тұрыңыз. Okay, I need to change the AP. Pull a little bit the coil and push the microcatheter inside the aneurysm. There is a resistance. Yes, it's all inside the aneurysm. Okay, let's do the control. It's not look like artery, yes? It's look like aneurysm.
Looks like aneurysm.
Okay, I think it's enough. One coil is enough. Yalta, what do you think?
Yeah. I think so. Yeah, I think so.
Okay. Shaykh Ahmed and Yalta agreed to finish with one coil. Okay,
30% pendiyorsun.
kesin bir sekund. Never do like this, okay?
Güzel, zaman pendiyor.
Açılır Keresini açılır. Okay, let's try to do control and draw. I deflated my balloon, coil mass is stable, and 3D we can see the aneurysm is filled by coils. Now it's possible to do angiography. Now I think Shaykh Ahmed, could you compress the left IC? Okay? Okay, no problem. It's near the esophagus. Near the trachea. Yeah. Okay. Just compress the left side of the trachea. Okay? Okay, just keep it. Left side. He's compressing left side. Okay. It's okay. Jason. There is a second. Yes, it's okay. There is a second AC. No. Okay, let's check. Okay, stop. Yes, there are two ACs. Yes. Clear. Jason. Yes. That's okay. Okay, and this is also okay. Bir çaşka verirsin. Now we will do the procedure we called hijama. But before I will do
Traditional medicine. After
it's Arabic medicine. Yes.
Huh?
Hijama is Arabic medicine. Yes. A second.
after regular medicine and after high-tech medicine, we do traditional Arabic medicine.
Okay. Now I will take out this one, and maybe you will give me 20 cc syringe. Okay. I will do aspiration. Okay. It's rubbish. Okay. Yes, MC territory is presented. AC territory already in place. And IC is a little bit spasmodic, but it's okay.
Хиджам когда нужно делать?
Когда инструменты выбираешь всегда.
Всегда, да?
Yeah.
После долгого постоянного.
Yes. The blood aspiration or blood delivery is a very important point of every procedure because we create spasm, and most common complication of these operations are thromboembolism and hijama, so-called hijama endovascular. It's a technique preventing those thrombotic complications. Yes, there is a spasm, but it's okay. There is no dissection, it's just a spasm. And we can go for the left side and check and finish. A second. 35 проводник, пересешь? 35 проводник. Okay. I asked for the wire to switch for the left side, and I will control left side, and then we will finish. And usually, if it's necessary, we can place the stent and we can straighten the kinking. Yes, I see. Yes, and today there is no indication, but if patient has any TIA symptoms, it's possible to stent this kinking. It's okay. Yes, everything is clear. AC territory is okay. Now we will do control CT. It's mandatory for all cases, and then we'll switch for the next patient. Yes, on this screen you can nicely see roadmap and the left side. Yes, Shahmin. Yes.
Nice.
It's nice. It's a 6D.
Yeah.
I just put the 3D roadmap and just angiography from other side. Thank you, thank you. We will wait for the control CT. Скажи, ехать пациент второй. Сейчас КТ подождем. Ну, звук пускай стоит пока. Бах. Давай все по плану. Сейчас КТ сделаем. КТ. КТК.
Там что-то за
Система вызова у нас через пациента.
Следующий под наркозом, да, оған там, по-моему, среднемозговой фубукимен кресломыз.
шығасаңыз КТ.
Сізге жасап жібере салайық па КТ-сін?
Спирать плавно не гепарин керевист, да?
Okay. Not all the time necessary to give heparin. Biz lan kulikten kalkış hazır. Yes, the city control is ready. This is contrast enhancement because of the flow arrest, I think, and the aneurysm level is clear. Now we can finish. And next case would be in 30-35 minutes. Thank you. Have a good day.